Welcome. Looks like we've got a number of folks who are here who were not here for the first part. So welcome. Thank you for joining us. So we are going to be talking about present and emerging issues impacting Middle Eastern and North African communities. And this is our second part through the Just Medicine Committee and CFHA. We're really happy to have you all here and our wonderful group of panelists. We were actually scrambling a little bit as there was a little bit of confusion between the times. So we have a couple of our panelists and more might be able to join over the next few minutes. So we'll see. So we have Saba Ahmadi. She is a doctoral candidate from the California School of Professional Psychology, and she's about to go on internship, and she's a very active member of the Just Medicine Committee, and we're very, very happy to have her. And we have Dr. Nicole Fleisher, who is a pediatric psychologist at St. Christopher's in Philadelphia, and she is actually my geographical neighbor. I'm also in Philadelphia, so really happy that you're here. And so the goal of our session today is really a continuation of this wonderful conversation that was started several months ago when we did our first MENA panel. And we wanted to continue and deepen a little bit and to ask our panelists some more questions about themselves as MENA identified providers and how it is to serve MENA patients. And so in preparation, we had asked each one of the panelists to pick a question that they wanted to focus on. So we're going to go there first and ask those questions. And as we're talking, we do want this conversation to be more informal. And so if there are questions that are coming up, or if you want to use the chat, please go ahead and do so. That would be really great to have it be more of an actual conversation than us talking at you. And so we'll start off with the first question. And Saba, if you can help me, just I don't have it in front of me, which one you were asking. Was it this one? I think it was this one, right?
Yes. So, hello everyone. My name is Saba. I am a doctoral candidate at CSVP San Francisco. I also am currently training with the city of San Francisco. My question is, what are two common clinical issues that MENA identified patients present with over the past year or so? And so how I'm going to answer this question is in the perspective of one, the client, and then two, as a service provider. So the first prevalent issue that is coming up for MENA identifying individuals is what's actually going on in the news, which is gender-based violence that is occurring within the Arab and MENA region. And before I can kind of dive into the specifics, I wanted to provide some statistical information for folks on this call. At this moment, nearly 37% of Arab women face a form of violence within their life that goes unreported. Another important statistic to consider is nearly 6 in 10 women who have experienced this form of violence do not report it or refrain from asking for help. Many human rights activists have actually brought this to people's attention and saying this is a major concern, but these human rights activists are actually encountering a lot of threats, a lot of violence, a lot of negative responses, and are being ignored, and therefore are being resisted in terms of being spoken to. This has led into what is the core root of this problem and why are things not moving. A lot of this has to do with the men that are making these rules. And so individuals might be wondering, where did these men come from? Well, these men were Middle Eastern men who were once young boys, who were very young and free and very open to different parts of society, but then started encountering different social systems, such as religious, such as schools, such as social factors that were presenting them with specific messages that women are not equal power players, but are considered to be objects. and that they need to have a sense of control over this demographic and over these individuals. What has made matters specifically worse is that these individuals who are encountering these kinds of social and conditioning and these different kinds of factors within those systems that they interact with, social media essentially kind of contributes to positively reinforcing a behavior that violence against women is okay, because what they're now able to do is to log on to social media and see what's going on in the world and see that it's okay when it's not really okay. All of these things put together has led to significant amounts of violence against women. Some of the specific events that have come up is attack on multiple women, specifically Nahira Sharif, who was a 20-year-old student who was attacked by a man because she has rejected his advances for marriage, and therefore this man had attacked her right in front of her university. There was also an attack on Iman Rashad, who's a 20-year-old nursing student who was in Amman, Jordan, who was tragically killed because she also rejected advances from a man and therefore was attacked and murdered. In Iran, a 22-year-old Kurdish woman was murdered on Tuesday for wearing an improper hijab. She was actually taken in from the police because they saw her in the street and they attacked her in the van and they murdered her. And one of the reasons that's specifically coming up for Arab and MENA women is this aspect that there is a whole war that's being fought in their homeland and their country, and they're unable to really address those things, but also the war here within the United States in terms of addressing the overturning of Roe versus Wade. This battle is not only just established here, but it's established everywhere. And Arab and MENA women need to have that kind of support and that kind of guidance in such a difficult time. Another thing that specifically comes up clinically and the perspective of the service provider is the lack or limited amount of trauma-informed, culturally responsive care and working with MENA identifying population. I'm very fortunate I get the opportunity of working with my community, yet as a upcoming clinician, I always have to go back and connect to the research. And for me, one of my largest struggles is this aspect that there's very limited evidence-based practice that shows positive outcomes or even takes into consideration culturally competent mental health services for the Arab and MENA population. This in turn leads to significant mental health disparities, specifically targeting diagnoses oriented toward the treatment of PTSD with Iraqi refugees who are more likely to be prone to be experiencing significant symptoms. A majority of the Arab and MENA population have a high risk of developing diabetes. Arab and MENA women are less likely to go in to get cancer screenings because they are not able to receive culturally competent care. With all this in mind, I think it's really important to put at the forefront of how are service providers actually providing this care? What resources do they need to provide this care, and how can we bridge the gap clinically? That's where I'm at.
Thanks, Saba, for getting us started. That was a lot to digest, and something, as I'm just kind of reflecting, that didn't come up pretty much at all during our first MENA conversation was this violence against women, and it is such a emotional, such a poignant topic, and something that I'm assuming that other MENA identifying clinicians and other committee members or CFHM members on this call are also probably feeling. Nicole, I wonder if you can comment on that, and I welcome anybody else in this room to comment on that as well.
No, I definitely think that Saba brought up a lot of great points that are impacting MENA individuals individuals both in their home countries, and it impacts them here. If I can tell you, while I was born in this country, my mom is an immigrant and a refugee, and watching some of these things happening on the news that are going on in her country of origin, and even in watching things that have gone on in Ukraine, in Iran, all of these regions have brought up a lot of things for her, and have led to PTSD symptoms, have led to somatic symptoms, and that's reflected not just in her, but in many in our community, even within the United States. So being mindful of, even if you don't always know what's going on in the news, because our news cycle in the US doesn't always bring these things to light. Some of it is kind of this perception of, well, that's just the norm there, which it is not the norm there. I am not going to get on a soapbox today about colonialism and imperialism and how that has informed some of these violent tendencies. And it's not necessarily an inherently reflective of those communities, but rather reflective of how different ideologies have been introduced into the regions instead. But being mindful of, even if you don't know exactly what's going on, many of these families have experienced trauma at some generational level. And just to have a trauma-informed approach to care, whether that's being mindful of your voice, being mindful of the language you use, being respectful of whomever is in the exam room with you or whoever is presenting for clinic. If you have an elderly patient and their daughter is the one handling their care, being mindful that that's something that is reflective of the community, and just really trying to have that trauma-informed approach because of all the things that Saba mentioned that are ongoing. And it does reflect too the things that are going on in the United States, the trauma of Roe v. Wade being overturned and how that has impacted these communities, regardless of their religious affiliation. MENA women still do, and MENA individuals who can get pregnant do access abortion services. It isn't something that's not seen in that community. So it is another additional trauma, and it is something that, due to some of the honor culture in that community, they may need to be a little bit more discreet about those services. And with some of these restrictions in some of these states, it is making it more and more difficult to be discreet. I realize I might have gone off on a couple tangents there, so I apologize.
No, I think it's such an important point, and there's just so much going on in our socio-political climate in the U.S. and outside of the U.S. And keeping all of this in mind as we all are treating MENA identifying patients is super important. It also made me think of what's on my social media feed and how other things just tend to take priority, like I can't remember her name, which is terrible. I'm terrible with names, but the runner who got murdered recently, and how that kind of overtook my Instagram and my Facebook and Twitter, and how some of these other things that are happening both within the US, but also certainly outside of the US, don't necessarily get the attention that they deserve. And then the assumptions that people make about, well, this is the norm, right? I think that's such an important point. Same with, right, this is a theme that certainly came up during our first MENA community conversation, was differentiating, or at least being mindful of collectivist cultures, and how, right, that really does create a different bond with family and outlook and seeking out medical care, and something that we certainly have to be mindful of as providers. Any other thoughts or questions? Please feel free to utilize the chat if you're not comfortable, saying it on video or audio, but certainly welcome this to be a collective discussion. Well, as we give people time to think and digest all of this, I wanted to turn to Dr. Fleisher and ask the next question on our list. So I'm going to share the screen one more time. Nicole, you were asked to reflect on recommendations for how medical and behavioral health clinicians should approach MENA patients when considering the incredible diversity in geographical, cultural, and religious backgrounds of the MENA community.
Definitely. I mean, I think we emphasized in the first talk that this is really a heterogeneous group. It's made up of several different ethnicities, languages, religions. I know that many may identify the area with like Christianity, Islam, and Judaism, but there are several other religions that are reflected within these communities as well. Some are more indigenous and kind of smaller sect religions, but that makes it really difficult to kind of learn the nuances of all of these different groups at one time. I will say, based on your geographic location within the United States, certain MENA communities tend to come together. So I know in New Jersey, there's a large like Palestinian population, and there's one in Jacksonville as well. Michigan has kind of like a melting pot of different communities, but being mindful of maybe who is in your region and being a little bit more aware of what are some of their specific presenting concerns, maybe, or health disparities, or even just cultural considerations, knowing that maybe there is a larger Muslim population and how that might influence their medical care. As Saba mentioned previously, women might be less likely to present for cancer screening services, so breast cancer, cervical cancer, those type of things, and that's something that we're still researching, but that might be influenced because of their perception of being Muslim or being MENA. It also might be due to education and practices from their home country compared to here, where they might not have had access to preventative services. So trying to learn what you can and trying to engage in that continuous education that we're all doing as professionals, while also recognizing that you're human and you can't learn everything. Even as someone who identifies from the community, I don't know everything about every single MENA person. There are definitely things that I can join with from people from my community, but I don't always know everything going on. And even considering my region and where my family's from, there are differences in the experience of Muslims versus Christians in our community. So kind of just being aware of what the individual's religion is and how that might influence practices. Also to like just be aware of that importance of family, especially for those who are maybe more recent immigrants or refugees. They might be attending their visits with a family member, not just for interpretation services, but because the family member might be their caregiver, might be just their emotional support, might be the only person they really have to advocate for them. So I know that in some cases, especially in adult care, we might not always welcome an additional family member, especially in the times of COVID. I know this was more difficult because we wanted to be mindful of how many people were in clinic for safety reasons. But for that individual, that community, it might be important to have that person involved in their care, even if it is more on a phone call or video chat level. That's still something. Also being mindful of our implicit biases, and we're human. I just had this conversation with my externs today in supervision about we all have implicit biases and being mindful of our biases and working on them. But I wanted to just bring attention to this because there was a research study that came out in 2015, specifically with Muslim American individuals and the discrimination that they perceived from the medical field. This included many microaggressions that I think sometimes we don't always think about unless we are from that community or unless we know people and have worked with people on a long-term basis. But things like someone who is inpatient for a procedure or is hospitalized for an illness and being served pork at breakfast, that is considered haram. That's a microaggression. That's something that we want to be mindful of. So making sure that halal diets are offered, those type of things, being mindful of women who are presenting in more traditional clothing, maybe a hijab, or who aren't presenting in traditional clothing, not making assumptions that they don't practice Islam because they're not wearing a hijab, because as we're seeing in Iran right now, the hijab does not define your level of commitment to Islam. So trying to kind of check those biases when they come up. Again, we're human, but just being mindful of those things. Having some curiosity too about the families that you see, but balancing that curiosity with not having the family educate you about their culture. One positive example I can think of is one of the pediatricians I work with. He consulted us on a young boy who was in the process for being evaluated for autism, but always had positive things to say about the family, because every time they came in, they shared their Moroccan culture with him, whether it was bringing him a small gift of oil, or a small treat that they made at home or they brought back from Morocco. He was always very appreciative of this. And he asked, like, oh, well, what does this mean to you? Like, how is this important to your family? Those type of questions. And that really helped build the rapport for him and this family in setting up like success for long-term care, especially for a kid who has more special needs. So balancing that curiosity and that interest with your families. And I recognize, depending on your clinic and depending on how much time you have with a patient, you might not always have that chance, but even just a brief, like 2-minute interaction can make a difference for some of these families. And I'm happy to elaborate if there's any clarity that's needed. I recognize that this is a lot of information.
I'm also like trying to take this all in, because it is really, really valuable information. I was just thinking for Saba, for Dr. Fleisher, and Dr. Siddiqui is also on the call, I'm going to introduce in a second. I was wondering if you have specific recommendations, just as far as what you were saying, Nicole, for questions that we should be mindful of when we first meet a MENA identifying patient. Are there specific things that we should be asking that we might otherwise miss, or that's more relevant, just as we even get their story as they're coming in and talking about their medical or mental health concerns?
I think from a medical perspective and thinking about health behaviors, being aware of maybe what generation the individual is from and who in the family is what generation, because we know that health behaviors differ between like first generation versus third. Also, this is a question I ask almost every family. I work in North Philadelphia. We have a very diverse population here, so I'm encountering diversity every day, multiple times a day. So one question I ask when I meet a new family, when I meet a new patient is there something regarding your culture, whether it's within your home, within your family, or within your broader culture, that you want me to be aware of that might inform your treatment? And for some people, the answer is no. There's nothing I can think of. And for some people, there are, I've had a young man sitting in front of me saying, yes, well, I'm Christian and we are very involved in fasting. And so in a weight management clinic, that does inform treatment. So being mindful of fasting and what that means for creating dietary plans for this individual. So that's a general question I tend to ask all my patients, regardless of their background. And I think can be really helpful in identifying what aspects of somebody's culture they feel is important to know. That being said, some people might answer no, and you might find out later on that there are some things that they are very valuable to them that might impact their treatment, and just being aware of that. Sometimes I do provide examples like, sometimes we just want to be mindful of your religion. So we provide recommendations that are in line with your religion or spiritual practices. We want to be mindful of any prayer schedules, of any dietary restrictions. We also want to be mindful of family dynamics. Like, is it okay if I update this person? Do you want them involved in your care? How much involvement do you want? That type of thing. So if you do see things that maybe the patient isn't saying yes to, it is okay to ask some of those questions.
Thank you. It's super helpful. And any other comments or questions about what we've said so far? again, I just think that this is such a rich and deep conversation, and I would love for us to, for you all, the other ones joining in the room, to feel comfortable asking whatever's on your mind. Again, as you think about those and throw them in the chat, wanted to introduce Dr. Saima Siddiqui, who is also our panelist and joining. It does say Tanya Vishnevsky under her name, but it is Dr. Siddiqui. She's a family medicine doctor and associate professor at UT Health San Antonio. And I'm going to just share the screen again in 1 second. And Dr. Siddiqui, if you're good with going ahead and telling us your reflections on the question that you were asked. So I'm doing the share screen now. Here it is. So what would you identify as one of the most valuable and effective culturally informed resources MENA patients possess? For example, rituals, traditions, morals, values, etc.
Thank you. Good morning all, or good afternoon all, thank you. So the thing which I came up with was a journal characteristics which I think all MENA patients possess for the feeling of or having feeling that there is someone controlling you. Everything is not in your control, which indirectly results in a lot of prayer, gratitude, and being satisfied with their whatever the outcome is in most of the situations. So this is the first thing. The other thing is that most of them, even though they are refugees, but most of them have their a very strong social support system, which helps them to solve a problem. So this is the positive aspect of that. So for example, if they do not have or missing a lot of things in their life, they will still be showing gratitude and satisfied with their condition. But on the other hand, it will also result in a lot of inhibitions in expressing the feelings of depression, anxiety, expressing the pain to the full extent, and the things like this. So I think it goes both ways, but it is the basic characteristics or common characteristics which I found in most of the patients belonging to the MENA community, whether they belong to whatever culture or religion or whatever their background is. But there is this spiritual content which is common in most of the patients.
Can I ask your thoughts of where the gratitude and the appreciation come from?
The gratitude and appreciation come from the feeling of someone being a higher being, and whatever they are getting is not what they deserve, but it is given as a gift. And the culture of looking at the people who are having less means than themselves. So that is the basic reason for the gratitude, and that is the basic attitude which is told, or which is basically taught to them from the beginning.
Do you think that is still applicable, or is quite as apparent for generations who have been in the US for longer? Do you think, I guess what I'm asking is, how does that get impacted by those who are more and more enculturated or more and more immersed as being part of the US culture?
So it is, I think it will be present to them in a certain, I will say, percentage still. It might not be to the same extent as the generations who recently migrated or who are, I will say the older ones, but it can still be there because that is the feedback they are getting constant at home. But as I said, on the other hand, it will also result in a lot of inhibitions and frustrations. So it is going both ways. It will also result in cultural clash among the younger people or the generations who are in US for some time. But basically, that is the common characteristic which I still see in the young people who are born and raised in US or living in US for some time. And the second thing about this social social, I will say, network, which is quite strong. So it also serves both ways. So on one way, it is a lot of support for them, but on the other hand, the young generation also sees it as an interference in their usual circumstances. So that is the thing which I observe. And the other thing is that in our clinical, if I will apply it in our clinical practice, we need to be really, really careful, because the patients who are coming with their parents or with their relatives we are expecting that it is the patient privacy which should be prominent. There is a lot of cultural things which interferes with that. So the patient's relatives and parents or guardians wants to be in the setting, clinical setting, when you are communicating with the patient. So I'm not sure what is the experience of other people or other clinicians, but that was my experience in our setting where we are practicing.
Saba and Dr. Fleischer, any comments from you both as far as your experience there? I wonder what there's so much individual differences depending on the person who's in front of you, right? And every single person, every family will be different. It's not easy to answer this kind of in a generalist way. But again, just thinking of a framework of how to kind of respect the closeness with family while also still trying to serve the individual, and how you navigate that when you're in front of patients.
Dr. Fleischer, do you want to go first and I'll answer it after?
Sure. I think, Tanya, as you were saying, it differs based on who's in front of you. I work primarily with children and adolescents. So I have gotten very used to asking families if they can step out of the room to talk to the adolescent or the child one-on-one about things going on that they might not feel comfortable talking about in front of parents. And specifically with MENA populations and with other collectivist populations, I really kind of provide some psychoeducation as to why. And I try and provide them with like this reassurance that I will update them the best I can afterwards. In the state of Pennsylvania, if they're 14 and older, they have the control over their mental health treatment. So they get to dictate whether or not I'm updating parents and what I'm updating parents with obvious limitations in confidentiality due to SI and HI. But I really try the psychoeducation piece. I say, and I encourage, this is across the board for me, I encourage that communication between parents and adolescents. And I kind of say, this is a way for me to just help get that information so I can kind of provide a treatment plan for everybody, including parents, and really encouraging that participation from parents, even if I'm talking individually. So providing that psychoeducation, if the parent is maybe being a little bit more resistant about stepping out of the room, I check in with the adolescent. I say, are you comfortable with mom staying in the room, with dad staying in the room, brother, aunt, cousin? And if they are comfortable, I will proceed with their permission. And some families, that's how they want to structure things. They want mom involved, they want aunt involved. And in some families, and I see it with both immigrants and with families who the adolescent may be born here and maybe a little bit more assimilated and the parents aren't as assimilated, it's really hard to tell who is going to be open and who isn't, even being from the community. So just having that conversation prepared and ready to go when I step into a room, not knowing what response I'm going to get.
I love that. And I think that's a reflective of my training, my clinical training, and kind of my approach as an immigrant myself is never make assumptions, right? Never assume that their experience is going to be your experience and vice versa. And just keep those the open mind and the open questions. Saba.
Yeah, okay, so this question. I think something that I really put into perspective while I'm working with the different families that I encounter on a regular basis is this kind of, I guess, understanding about the implementation of certain interventions in culturally competent care. I think something that really comes up to me in clinical training is there's this expectation of like constantly thinking about all these things and constantly delivering. And I think when working with such a sensitive population, such a population that has been under researched, under considered in clinical training, I think it's important to work at a very slow pace and very cautious pace before thinking about implementing these new things. And for me, by taking this notion into my own clinical work, I have found that the work that I have thus done by providing such care has really destigmatized the accessibility of mental health services, but also clients are more likely to come back. And I think that within itself is really important for service providers to take into consideration. I hope that answers your question. Does it or not?
Yes, it does, and adds extra layers of good things to think about. I love the idea of taking it slow. So I'm going to pause here to introduce our final panelist. Thank you so much for being here, Dr. Ali. There was a scramble as we were working on 2 different times, and this was on me, by the way. I had messed up the time, so I will own it. So let me just introduce you. Dr. Fozia Ali is an associate professor at the Department of Family and Community Medicine at U of T San Antonio. And the question that you were asked to think about and answer is a great one and ties in beautifully just as we are in this conversation. And that is, tell us about your experience being a MENA physician. What kind of challenges have you faced?
Okay, so I'm so glad that I was able to make it. I was just finishing up with patients, so sorry to be late. But I think when it comes to my experience, I'm glad that I have several patients on my panel. I have been trained in this program where I practice as a physician. So the patients I've been seeing there since my residency training since 2008. In terms of like, I think it's a great experience, the things that I really like. Once you develop the trust and once you become their family physician, it takes time. But once you are able to get the trust level and provide the culturally sensitive care, they're very faithful. They find you. Like I have patients, I don't speak Arabic. I can read and write Arabic, but I count on my interpreters when it comes to Arabic. And my patients, even I schedule them with someone who speaks the language, and they still come and find me and they want to see me. So I think that's one thing I'm so grateful that they, the trust once it's there, they bring their family members. I'm being grateful that I'm seeing not just one person, I'm seeing sometimes the family of 4 together. And I have to sometimes separate them in different rooms, in terms of like if their parents are coming with their children or their grandparents are there. But that's one thing I've seen, like once you know the family, it becomes easier to provide care. And sometimes it's challenging. The challenges, I want to talk more about the challenges and the barriers. And I think that's probably most of us will agree that I was just hearing the part of it when I joined the meeting, the culturally sensitive care. I think that's one of the challenge. The other day I saw a patient who I've been seeing since it's over 10 years. And I feel each time I use interpreter, that's a challenge. If I'm seeing a female physician and if the interpreter is a male, then they're hesitant to talk about, particularly about contraception, about the women's health topic, anything, for example, pregnancy care or infertility. And overall, I was talking to one of our residents earlier while seeing a patient earlier this week speaking Arabic, that I think also the sex education are the overall, like in terms of like the contraception, it becomes sometimes harder. Like you have to spend time and maybe just devote a whole visit to it versus just talking for a few minutes for this, because you have to probably spend time to talk about, we're talking to this patient about contraception, and then it seems like it was just kind of like a new thing for the patient. So that's something I always still feel like we need more training. A lot of screening tools for mental health, and those tools are sometimes hard to apply to specific population. And we rely on those tools. For example, intimate partner violence, so we ask them. So, and sometimes it's hard, we can still miss the information. And especially when their spouse is in the room. So you have to also learn how to request them to be outside, and you ask patient the questions alone as well. Infertility treatment, that's something I found challenging sometimes if they want to talk about, and if what the partner wants and what the patient wants, and just kind of like a shared decision-making approach. So the other thing is I notice a lot of times the patients, when in the beginning of my career, I have this challenge that when we would ask these questions and talk to them about these medications and behavior health, they have this kind of sense of like losing trust, and they would ask me like if anyone in the community would know this, that they're taking the medicine for depression or for anxiety. So I felt like that kind of the losing privacy, that was a fear, and they noticed, and then they reported, and they were worried, that if other person would know that if they're taking. So the stigma, we need to also accept that that's there, but at the same time, we cannot just keep it. We have to find a way to overcome this. When it comes to the family care, when you're seeing a couple, so and even you're seeing a patient with the spouse, and spouse gets involved in decision, so you really need to make sure you're talking to your patient and keeping them in the decision making, and making sure that you listen to them. And also you need to keep the family. You can't separate them. The dynamics is important to them, but at the same time, making sure your patient, it's being centered in the decision. I don't know if you also notice inpatient setting, we also work as hospitalist, and the advanced care planning discussions, the goals of care discussions and specific population is harder because most of them, they don't have concept of hospice or palliative, and you're the first physician talking to them and first time bringing this up. And then there's a whole family involvement. So, and we have interpreters, and you have to be careful that, what language and how you're gonna approach that. So I feel like even like being their continuity physician, I'm still learning. Each time I see my patient, I end up learning something new. I have, it really helps my practice also, because when I approach them with curiosity versus assuming, one of the example is observing Ramadan. We should not just assume everyone is observing Ramadan, right? We need to just be, just know, we can ask them what their practices are, and before giving them advice or before giving them any recommendations. The similar thing comes with the screenings, screening for substance abuse, for tobacco, for alcohol. I think we should not assume that if they're coming from this community, they're us. I think we should just we should be curious, we should be asking them and approaching with a cultural sensitivity, but I think we should still ask those questions. So those are the things that I have used in my practice, meeting everyone with curiosity and just asking with respect and knowing their perspective. As sometimes the patients are hesitant to answer, but I think it's a trust and it's the continuity of care that helps us. And being a family physician, that's very rewarding, because I will see them more than one time, and that's I think those are the things that I felt. But if there's anything else, any questions, I can answer. I know the time is limited, but there's a lot to know and a lot to share. And the more we see them, I think that's we are getting more practice, but at the same time, we probably need to come up together to find out tools for how to screen them, especially for mental health.
Mm-hmm. Thank you so much, Dr. Ali. And the themes of our conversation today seem to stand out to me in such a strong way. It just keeps repeating, whether it's from the vantage point of you as a MENA identifying physician serving others, or how you approach MENA patients, this idea of this curiosity and being open-minded, and just really looking at this from who that person is in front of you as an individual, not making any assumptions, but also having that knowledge and training behind you to give you the information that you need, and to have those, culturally sensitive and trauma-informed approaches, et cetera. So that is really, that's sticking to me. And I think that's just so important as we're approaching patients, any patient. I would love for others to pitch in, any of our panelists and anybody else in the room, if you've had experience as, identifying provider particularly, what has that been like?
I've definitely seen some relief from some of my patients when they recognize that I am from the MENA community. I have a German last name. My father's German, but I do have a necklace that has my name in Arabic, and some of the time they can still tell just based off of appearance, things like that. And one salient moment was I was talking with a mom who was Egyptian, and she asked where I was from, kind of knowing I was from somewhere. And when I informed her that my mom was Palestinian, her comment was, "Oh, you're our neighbor. You're just one of us. You're Egyptian too now. It's fine." So like, and that kind of opened a door to talking a little bit more about what was going on. She was there for her son who was having GI concerns and like psychosomatic concerns. And it's not necessarily that every patient that walks in the door, and I don't always like disclose, not because I'm hiding anything, but it's not always relevant to the situation. But there are things that I wear to work, like my necklace. Sometimes I wear like the Palestinian embroidery to work that patients might pick up on. And I've definitely seen like a change in their demeanor sometimes when they realize, okay, there's someone here from my community who will maybe understand a little bit more about my background, what I'm going through. Again, like working with one Palestinian family who just happened to be from the same town that my mom is from, that helped them kind of open up again in the session, because they knew they didn't have to repeat all of the trauma that they've been through to come to the United States. They knew that at least I could kind of assume what they'd been through at that point, given that we both come from the same town and come from the same community. So it's been a way to join with patients and have them feel a little bit more understood in a setting that is sometimes fast paced, sometimes does not always get to the person as a whole when approaching their care.
I'm going to answer this in a perspective of a bilingual, bicultural clinician. One of the most valuable experiences that I have is providing care in my primary language of Farsi. When I have the opportunity of doing that, and I'm working closely with the youth and the family as well, I notice a sense of relief, because oftentimes languages are really beautiful, but not everything gets translated. And the utilization of the interpreter is really great too, but oftentimes little things get missed in that moment in time. For me as a clinician, when I get to kind of put the interpreter aside and just be with the family, it's different. They feel heard, they feel seen, they feel like there's someone on their team, they feel as though they can take the next steps to receiving the care that they do deserve. Yeah, stick to that.
Dr. Siddiqui, I'm not sure if there's anything else to add from your perspective. And you are able to jump on. Okay, great.
So I will agree with all the things said, and then as a clinician, seeing the MENA patient, the conflict which I found in myself, I think somebody mentioned it also, that to control my own bias, that is the first step, because as soon as I see the patient, there will be some assumptions based on my cultural background and my extra information for them. So I have to control my own bias and then start the consultation. And as Dr. Ali mentioned, developing confidence and patient relationship is really, really important. I also ask the patients to go out of the room and then clarify before asking the questions, which does not seem culturally appropriate in some cultures or in front of the parents, that I have to ask as a clinician to clarify that. End of life issues are also another important discussion, which is little different than the usual discussions we have. But as I said, as a clinician, the first step, I think, is to control my own bias when talking to these patients.
Now, I also have to reflect that our wonderful panelists all happen to be female as well. We tried. We tried really hard to have a male perspective as well. He was not able to join us, unfortunately. But I'm wondering, since we have these amazing women in this room, can you comment on what it's like as a female and being a MENA physician or clinician from a female perspective?
I think it's kind of a strength I take as a strength. Like, you know, when I go in the room and knowing the culture, and again, I get a lot of patients because of my last name is Ali, and they think I speak Arabic and I'm fluent. I greet them in Arabic, and I know words. I am able to understand few even with interpreter. It's just a language we had to learn growing up, but we don't. It's not my native language. But I think it's being a female, you're very, I mean, I feel like, you know, you get very sensitive in terms of when it comes to cultural values that the female goes, you know, and they respect. The other thing is that, you know, as Dr. Siddiqui mentioned, you know, have to keep our bias away, and also being more respectful, like, you know, to the, I have told the residents, you know, in terms of when you see a patient and they're completely covered, they have hijab, and making sure, you know, you ask them before you examine and make sure, you know, sometimes it's okay. You don't have to pull their, you know, gown up. You can just, you have to do through the gown. You have to still, in a way, like examining over the skin, but just being culturally aware and being sensitive when you're examining, listening to heart, listening to lungs, you know, very simple exam, but just make sure, you know, you still have you respect what they wear. I think that's kind of something I've noticed, and being a female, I respect that. The other thing is they're very open to me, and even I don't speak the language, I use interpreter. There are sometimes one of my female patient, actually, I recently saw her last week. I'm seeing her for a long time. She learned English, so she's fluent in English. She doesn't, I will still use interpreter because, you know, she's still kind of learning the language. And if she's able to speak English, I'm able to listen to her. She asked me if I can mute the interpreter for the time being, and I can unmute when I need it. So I've done that, and that helps me to develop that relationship that the patient needs, and just to keep the trust. So I think that's kind of our strength, you know, for a female physician in providing care, especially to even female patient. In terms of male patient, I think it's also valuable because I do, when I do take care of any male patient, for example, I saw someone with diabetes. So I asked him, you know, who's cooking, and I know his wife is cooking for him all these delicious food. And I just kind of approached with that. And he was like, yeah, how do you know that? Yeah, she's cooking and I'm eating and I cannot say no to that food. So it's like, can you bring your wife next time? You know, I can talk to her. So I think that approach helps. It's more personable and it really helps your patient. So knowing that culture. So yeah, that's all I have, but I think I'll give time to others to also share their thoughts.
I think working in the pediatric world, I would agree with Dr. Ali that it is a strength. Kind of just the nurturing role that many women take on in the MENA community, and kind of just that expectation. It's seen as a strength here. Like they see a female clinician, a female psychologist, and they think like, okay, like that empathy is there, that understanding that approach. And that's not saying that our male counterparts don't have that approach. It just allows for that relationship to build, especially when working with kids and adolescents. There is a little bit less of that that like cultural expectation that you're working with a same-sex clinician in regards to working with children than if you're working with adults, because there is that more flexibility. I still very much am mindful if I'm working with a teen male. I check in, I say like, are you okay working with me one-on-one? Or I check with the parents, like, is it okay if we talk one-on-one, like to be respectful? But usually it's perceived as, yeah, that's fine. And it's, I agree, it's a strength, and like not to reflect that that's anything against our male counterparts, because many of them can also do just as great of a job, but it's sometimes getting over another barrier that we don't have to get over.
What's it like being a MENA service provider? I think in this moment of time, because I'm still in like, you know, training and I'm still learning stuff, I think something that has been really affirming in this process is something a supervisor shared with me, which is I know what I know, but I can always learn some more. And I think I've had this beautiful opportunity of collaborating and working with Arab and MENA individuals in both, youth context and as well as family context. And they have taught me this aspect of maintaining the sense of curiosity, but sense of kindness and wholeness throughout this process. But also, there's just so much more to learn. I don't know how you all feel, but for me as a clinician, like there's this whole generation of youth who are bringing in these new terms and these new experiences, and it's so cool. And for me as a clinician, I got to spend some time getting to know what's in the news, what's trendy, what's cool, and how will that affect or even yet benefit this upcoming generation of, clients and people that will be a part of our community.
I suspect Mi Young feels the same way as sitting here and listening to this conversation, but I have found this community conversation to be so incredibly uplifting because I hear you all doing just this amazing work, and it helps to give me passion to bring this to my own clinical practice as well, right? To continue the sense of curiosity and to seek out diverse clients in these various populations who need so much support right now. And I just want to thank each and every one of you for being here today. Thank you for scrambling to show up an hour early. We so appreciate it. And our other people who have been in this group have been quiet, but please feel free to reach out to Mi Young or myself. Send us email questions. We will forward it along to our panelists. And thank you so much for being here. Really appreciate it. So I just want to respect everyone's time. It's almost 1 o'clock, and Dr. Siddiqui, I'm not sure if there were anything you wanted to say as we closed up.
I just want to add that I agree with that being a female with MENA population is a strength, but on the other hand, you will see few male patients and they will be hesitant to discuss their problems, even though they are very comfortable bringing their wives and their children, that this is the first immigrant. But sometimes you will feel, you will have this issue with the immigrants who are in US recently, so first generation. But otherwise, most of the time, it will be a strength for me also.
Thank you. Thank you so much. Well, yes, I hope to see most of you in Boise who were able to attend. And thank you for joining today. I wish you all a good rest of your afternoon and morning. Take care.
Thank you. Bye-bye.
Thank you.